moderating this session. And Dr. Noel Gomes, he has completed his DM from St. John's and he's working. Uh, no, pardon, 1 minute. So I welcome Dr. Noel Gomes. He is MD Medicine from St. John's and DM from Sion Hospital. And currently he is working in Nair. Hello, am I audible?
Yes,
Yes,
sir,
sir.
you're.
You are audible.
So I welcome Dr. Noel Gomes. He
Thank
is
you so
MD
much.
Medicine from St. John's Medical College, Bangalore, and DM Neurology from Topiwala National Medical College and Nair Hospital. And currently he is working in Nair Hospital. And I welcome Dr. Nandini Priyanka. She has done her MD from uh, Raja Muthaiya Medical College, MGR University, and DM from Thanjavur Medical College. And currently she is working in Lifeline Hospital, Adur, Kerala. And today, Dr. Ratnesh Sharma is and other who are willing to participate for interactive session, they can contribute. So we'll start. Dr. Noel Gomes, you can give your means intro in one line. Then we'll start. And Dr. Ratnesh, then we'll start.
Yes. Good evening, everyone. I'm Dr. Noel Gomes. I have completed my DM from Nair Hospital in Bombay. Currently, I'm working in Nair Hospital in Bombay. And I think we can start. And all the best to Ratnesh. Think
Thank you, sir.
we are expecting a good discussion on this topic.
Yes, sir.
You
Sir,
can
I'm
start.
Dr. Ratnesh, third year neurology resident in SVP Hospital, NHL Municipal Medical College, Ahmedabad. So I'll be presenting movement disorder related neuroanatomy, uh, physiology, and pathophysiology. Uh, shall I proceed, sir?
Yeah, it starts.
Yes. Sir, I'll be briefly covering anatomy components of basal ganglia, the basal ganglia circuits and its neurotransmitters, the various loops, major neurotransmitters, pathophysiology of movement disorders, and the blood supply. Sir, basal ganglia, the divisions are the striatum can be, the striatum is considered as putamen plus caudate. The paleostriatum is also known as globus pallidus. Lentiform nucleus is the putamen plus globus pallidus. The corpus striatum is caudate plus putamen plus globus pallidus. And other than that, modulators of basal ganglia are substantia nigra pars compacta via nigrostriatal pathway, locus coeruleus, and the median raphe nucleus. So the principal components are striatum, which is composed of putamen and caudate, and ventral striatum, which is nucleus accumbens. Globus pallidus has two parts: the globus pallidus interna and globus pallidus externa. The GPI lies medially, and the GPE lies laterally. The substantia nigra has two parts: substantia nigra pars reticularis and substantia nigra pars compacta. The subthalamic nucleus consists of dorsolateral STN, that is the sensory motor region, the ventrolateral STN, that is the associative region, and the medial STN, that is the limbic region. Sir, the basic overview of the motor system is the cerebral cortex decides when to move, it decides the direction of the movement, it decides the amplitude of the movement, and the emotional body language, which is all of this information is conveyed to the basal ganglia. The basal ganglia processes this movement and relays it to the thalamus, and after the thalamus, it goes to the cerebral cortex, going into the upper motor neuron system. This relays again further relate to the corticospinal tract, which then sends it to the lower motor neuron system, which conducts the movement. Cerebellum also provides input in the form of cerebellum receives proprioceptive input, vestibular input, and the environmental cues, which are further added to the input to the corticospinal tract. So overview of the basal ganglia organization is, so the striatum, it receives input from almost all areas of the cerebral cortex, and it receives modulatory dopaminergic input from ventral midbrain and substantia nigra, pars compacta. The striatum mainly outputs to the globus interna and the substantia nigra pars reticularis and the globus pallidus external. The principal projection of the basal ganglia is back to the cortical targets, mainly to the motor associated areas, that is the supplementary motor area, premotor area, and the motor cortex. The basal ganglia also provide the output to thalamus, influencing motor as well as sensory and cognitive processing. The superior colliculus hence influencing the eye movements, and pedunculopontine nucleus for postural control. So, short slide on cell types of the striatum. The striatum has major two cell types, that is the medium spiny neurons and the striatal interneurons. The medium spiny neurons consist of 95% of neurons in the striatum. They are mainly GABAergic. The direct pathway MSNs have D1 receptors and they facilitate direct pathway. The indirect pathway MSNs have D2 receptors and they suppress the indirect pathway, resulting in volitional motor movement. The striatal interneurons, there are four types, that is the tonically active neurons. They are mainly cholinergic. Fast spiking interneurons, they are mainly GABAergic. Low threshold spiking interneurons, they are mainly GABAergic with nitric oxide release. And thyroxine hydroxylase interneurons that are dopaminergic. The clinical relevance of the cell types is in Parkinson's disease, the loss of dopaminergic input due to degeneration of the nigral, the substantia nigra cells, resulting in loss of dopaminergic input via the nigrostriatal pathway. This results in overactivity of indirect pathway via D2 MSNs and underactivity of direct pathway via D1 MSNs, resulting in hypokinesia and rigidity. The cholinergic interneurons become overactive. They contribute to tremor and rigidity, especially due to oscillatory firing from ventro-intermediate nucleus of thalamus and and the subthalamic nucleus. The anticholinergics help restore balance. They reduce the tremor, and levodopa carbidopa supplementation reduces the hypokinesia and rigidity. In Huntington disease, early degeneration of the indirect pathway, that is the D2 MSNs, results in chorea because of loss of the surround inhibition by the indirect pathway, resulting in unwanted motor movements. The output of the basal ganglia is mainly via surround inhibition and direct action. So the direct pathway decides which motor command should be carried out, and the indirect pathway surrounds all the unnecessary motor movements. Hence, if the indirect pathway is degenerated, unnecessary motor movements occur, that is chorea. Later stages involve widespread striatal atrophy leading to akinesia, and the dysfunction in the cholinergic interneurons result in the cognitive and psychiatric symptoms of Huntington disease. In dystonia, tics, and Tourette syndrome, altered medium spiny neuron activity and interneuron dysfunction contribute to the involuntary movements. Moving on to anatomy of caudate. The caudate head lies in the frontal lobe. The caudate tail lies in the occipital lobe. The end of the tail lies in the temporal lobe, and it terminates in the amygdaloid nucleus. While putamen lies lateral to the caudate, the entry limb of internal capsule separates the putamen and caudate, leaving only a few bridging fibers between them, giving the striatum its striped appearance. Globus pallidus is divided into two segments, internal and external. Internal is involved in the direct pathway, while external is involved in the indirect pathway. The neurons in both areas have high tonic firing rates, and 95% of them are GABAergic and inhibitory. The subthalamic nucleus, the main neurotransmitter is glutamate. They are glutamatergic. These are targets for DBS and IPD because oscillations in estrogens are most likely responsible for tremor in the idiopathic Parkinson disease. Moving on to the modulators, that is the nigrostriatal complex. It is located in the midbrain. The substantia nigra pars reticularis is mainly GABAergic. It outputs to the basal ganglia. Developmentally, it is the output of basal ganglia. It is developmentally related to globus pallidus interna. Hence, it is grouped with the GPI. While the substantia nigra pars compacta contains neuromelanin containing cells, the main neurotransmitter is dopamine. It facilitates direct pathway via D1 receptors and suppresses the indirect pathway via D2 receptors, enabling the desired movements. As we can see, the degeneration of the neurons of substantia nigra pars compacta results in Parkinson's disease. Moving on to the pathways of the basal ganglia, that is the direct, indirect and
I would,
hyperdirect pathways.
Ratnesh,
Yes,
so
sir.
what are the inputs on basal ganglia pathways? What are the inputs, output, and the intrinsic components? Then we can understand the pathways better. So
Sir,
input is from which component?
sir, major inputs are from the cerebral cortex, sir, various areas of the cerebral cortex.
Yes. Cerebral cortex and thalamus and striatum also. This
Yes, sir.
this form the input pathway, or it forms the input,
Yes, sir.
and sometimes even nucleus accumbens. Then
Yes, sir.
what are the output?
Sir, major output is to the, sir, thalamus, various nuclei of the thalamus, and along with that, in the,
But the output component, where does the output come from in the basal ganglia pathway? It is from globus pallidus interna,
yes, sir.
and along with that, substantia nigra pars reticularis also.
Yes, sir.
And what are the intrinsic components which connect in the output?
Sir, globus pallidus and substantia nigra, and the, sir, the interneurons within the pathway, sir. They are the main
Globus pallidus externa, which forms the
GP.
intrinsic pathway, which connects the in indirect pathway especially. It connects the input to the output and the
Yes, sir.
subthalamic nucleus
Yes, sir.
in the indirect pathway.
Yes, sir.
Then what are the different neurotransmitters?
Sir, mainly it is in the substance from the nigrostriatal pathway. It is dopamine. Within the direct indirect pathway, main from the cortex to the striatum, it
Dopamine that
is
is from the substantia nigra
sir,
pars
from
compacta.
yes, sir.
Yes. Uh,
From the
then
cortex to the striatum,
subthalamic nucleus,
sir, it is mainly glutamate.
glutaminergic, and nigra reticularis,
Sir, it
reticulata,
is GABAergic.
it is GABAergic.
Yes, sir.
So it is inhibitory.
Yes,
It forms part of the output. So the
yes,
output
sir.
is usually inhibitory. Then is there any role of acetylcholine?
Yes, sir. Sir, the interneurons have activity, mainly cholinergic activity.
Suppose the cells in striatum. So the striatal cells, striatum contains cholinergic neurons,
Yes, sir.
and it has some effect on so the acetylcholine, it inhibits the direct pathway and it excites the indirect pathway.
Yes,
So
sir.
we'll come to that later to see what are the effects. Okay, you can go ahead.
Yes, sir. Sir, the thalamus is under tonic inhibition, which means that unless this inhibition is removed, there is no signaling to the cortex. The output from basal ganglia can either decrease or increase the tonic inhibition of the thalamus via direct, indirect, or direct or indirect pathways. Any upset of the balance between these results in motor dysfunction that characterize extrapyramidal syndromes. Sir, a simplified version of direct pathway. The various areas of the cortex give input to the striatum via glutaminergic neurons. This input is received to the striatum, that is caudate and glutamine, which further gives an inhibitory action on the globus pallidus interna and SNR via GABAergic neurons. The GABAergic neuron, the GPI and SNR have a inhibitory input on the thalamus, and the thalamus has a excitatory input, which means that whenever the cortex sends signals for a desired motor movement, the striatum inhibits the GPI, which results in decrease in the inhibition of the thalamus, which results in the desired motor activity. The direct pathway is excitated to the motor cortex, hence it facilitates the desired motor programs for current task. And sir, it is also under modulation by the nigrostriatal pathway via D1 receptors. Dopamine, the D1 receptors facilitate the direct pathway via dopamine. Hence, dopamine promotes desired motor activity. So moving on to indirect pathway, the cortex gives programs to the striatum via glutamate. The striatum has an inhibitory influence on the globus pallidus externa, which inhibits the subthalamic nucleus. The subthalamic nucleus has a excitatory, facilitatory input on the GPR SNR, which has a further. So in this indirect pathway, what happens is the striatum inhibits the globus pallidus externa, which inhibits the subthalamic nucleus. Hence, the activity of subthalamic nucleus is increased, resulting in increased inhibition of thalamus, which results in suppression of the undesired motor movements. The indirect pathway is overall inhibitory to the motor cortex, hence it inhibits execution of unwanted motor programs required for the current task. And so D2 receptors, they suppress the indirect pathway via nigrostriatal pathway. Hence, dopamine promotes the desired motor activity by inhibiting the unwanted motor activity. And third pathway, sir, hyperdirect pathway. The cortex directly stimulates the subthalamic nucleus, which stimulates the GPI SNR, which inhibits the thalamus. So, sir, this is responsible for inhibition. This inhibits the motor cortex, and this subserves the rapid inhibition of unwanted motor programs. Moving on to neuromodulators. So direct and indirect pathways both express distinct dopamine receptors. The dopaminergic input arises from substantia nigra pars compacta. D1 receptors are mainly present in the direct pathway. D2 receptors are present mainly in the indirect pathway. The strong cortical inputs and firing of the direct pathway neurons are facilitated by D1 signaling, which results in facilitation of the movement by a strong cortical drive. And indirect pathway, the T2 signaling suppresses firing in the indirect pathway neurons, resulting in suppression of the unnecessary movement, further facilitating the desired movement. So there is cholinergic modulation as well in this direct and indirect pathways. The cholinergic interneurons in the striatum inhibit the striatal cells of the direct pathway, and they excite the striatal cells of the indirect pathway. Hence, the ACH turns down motor activity while dopamine turns up motor activity.
Yes, so the dopamine,
Yes, sir.
right? So it actually exists or it D1 receptors, and because of that, the globus pallidus internus of the direct path in
Yes,
turn
sir.
decreases the inhibition of thalamus and the activity, and
Cortex.
yeah,
Yes,
in
sir.
that through the direct pathway. And what happens in indirect pathway?
So the D2 receptors receive dopaminergic input and they suppress the activity of indirect pathway, resulting in
Through externus,
suppression of unwanted movement.
that's externus,
Yes, sir.
and by external, how does it act? So it increases activity through direct,
Yes, sir.
unwanted activity through indirect pathway. And hyperdirect pathway is also inhibitory. So excitatory pathway is direct and inhibitory is indirect and hyperdirect pathway.
Yes, sir.
And acetylcholine,
Sir, acetylcholine
it
turns down
decreases,
motor
it
activity.
inhibits direct and it excites indirect. So basically it decreases, overall it decreases the motor activity.
Yes, sir.
Okay, go ahead.
Yes. Sir, there are two basic theories of motor control. That is the theory of lateral inhibition by medium spiny neurons. They are important in selection of the competing motor programs. Each medium spiny neuron has numerous inhibitor GABAergic connections with the neighboring MSNs, allowing to increase the signal to noise ratio of striatal output. And another theory is the feed forward model, that is inhibition by the fast spiking interneurons in the striatum. So other than movement, the basal ganglia also have role in the reward and language processing. The ventral striatum via nucleus accumbens projects to the ventral pallidum, resulting in integration of the limbic system and motor system. The ventral pallidum has a role in reward, sex, social affiliation, and drug abuse, while striatum also has a role in language processing, word retrieval, and syntax. That's why lesion of the striatum causes striatal aphasia. And along with that, sir, basal ganglia and cerebellum recently has been discovered to have bidirectional connection through the dentate nucleus. I'll move on to the basal ganglia circuits. So in addition to functions in the regulation of voluntary motor movement, basal ganglia also has connections involved in cognition, emotion, and oculomotor control. The basal ganglia has links to parts of the brain involved in behavior, memory, attention. The major cortical projections in the motor loop are mainly to putamen, and in the other loops, it is to the caudate. So there are four major loops: the motor loop, oculomotor loop, cognitive loop, and limbic loop. So the motor loop consists of the inputs from the cerebral cortex, that is supplementary motor area, primary premotor cortex and motor cortex, along with input from primary sensory areas and sensory association areas. All of this input goes to the putamen, which is further conveyed to ventrolateral globus pallidus and further conveyed to thalamus, that is the ventro-anterior and ventrolateral. And this input is refined and goes to the motor areas of the cortex. This is
So
responsible
this,
for,
so this motor loop is responsible for what?
sir, it is responsible for planning, initiation, and storage of motor programs and fine-tuning of the movements.
Correct. So pathology affecting the motor loop will lead to what?
Sir, it will lead to bradykinesia, rigidity, and tremor and incoordination, sir.
Yeah, so it can cause both depending upon what pathway it is affecting. It can cause either hyperkinetic movement disorder or hypokinetic. So
Yes,
either
sir.
it can cause bradykinesia and rigidity, or it can cause chorea, hemibalismus, those
Yes,
hyperkinetic movement disorders. Okay, go
yes.
ahead.
So moving on to oculomotor loop, the input from frontal eye fields and posterior parietal cortex is relayed to the central caudate, and this information is relayed to globus pallidus and SNR, which provides input to the superior colliculus for saccadic eye movements. And this movement is again related to the thalamus and to the association areas in the cerebral cortex. This is responsible for control of saccadic eye movements.
Correct.
Moving on to
So yes,
yes,
so now this basal ganglia connections that are affected in other atypical Parkinsonian disorders also. For example,
yes,
like progressive supranuclear palsy. In progressive
yes,
supranuclear palsy, the saccadic eye movements are affected. And since this loop is involved, it will cause saccadic, it can cause saccadic eye movement abnormalities also. For
yes, sir.
example, you see vertical gaze palsy, slowing of saccades, you see in atypical Parkinsonian disorders also.
Yes.
Go ahead.
So moving on to cognitive or associative loop, the prefrontal cortex, mainly dorsolateral prefrontal cortex, provides information to dorsolateral caudate. This provides information to globus pallidus SNR, and it is relayed via the ventroanterior or centromedial nucleus of thalamus to the again to PFC. It is responsible for planning of complex motor activity. And initially, when a new task is not practiced and well learned, it goes through the associative circuits. When it is well learned, the motor circuit becomes active, which is responsible for the automatic or subconscious movements, learned movements.
So if this loop is affected, so what uh, what will be the presentation or what will it lead to?
Sir, this will
Basically,
result in,
it is for planning of complex motor activity, right?
yes,
So,
sir.
so that is the executive function. So executive
Yes, sir.
motor function. So when this loop is affected, it will cause executive dysfunction.
Yes, sir.
So that's why we see because Parkinsonian disorders, including atypical Parkinsonian disorders, uh, they cause subcortical dementias, subcortical memory loss, as we say, and they don't present with cortical involvement like typical episodic memory loss. They present mainly with executive dysfunction, and
Yes, sir.
that is because this cognitive and associative cognitive loop is involved.
Yes, sir.
Okay. So, what all history or what will you do in examination to bring out this executive dysfunction?
So we can ask the relatives whether the patient has a difficulty doing sequential activities, such as making a cup of tea
Right.
or,
So, a female who was able to prepare tea is not able to prepare tea in a sequence which she usually follows,
yes,
or a male who goes to the bank and he knows what is to be done, like filling the form, depositing the money. He's not able to do that. He forgets the steps, or he's not able to use the remote control properly, changing the channel. Previously, he
yes,
was able to use WhatsApp, he was able to use YouTube on his phone, which is not able to do that currently. Though he
yes,
knows that this is the phone, he's able to identify the phone, but he's not able to perform the sequential actions of opening an app, watching a video on YouTube. So this will be
yes,
the history which will be given. Okay, now
yes.
move
So moving on to limbic loop, uh, major input is from the orbitofrontal cortex and anterior cingulate cortex. This goes to the ventral striatum, that is nucleus accumbens. This further goes to ventral pallidum and again to thalamus and to the orbitofrontal cortex. So this is involved in motor expression of emotions as well as in gambling, addictions, drug abuse, and reward pathway. Shall I move forward, sir? Hello.
Yes, you can move on.
Yes. Yes. So this is a short summary of all the four loops. Sir, moving on to the dopaminergic pathways. Main sources of dopamine are the lateral substantia nigra pars compacta, that is A9, the medial ventral tegmental area A10, and retrorubral area A8. So this is a flowchart of tyrosine synthesis. Sorry, sir, dopamine synthesis and metabolism. Tyrosine is converted to L-dopa via tyrosine hydroxylase, which is further converted to dopamine via dopa decarboxylase. Dopamine is when dopamine is released in the synapse, it is carried to synaptic vesicles by vesicular monoamine transporter 2, and it is further released into the synapse. It is reuptake by the same enzyme, and it is metabolized to dopac via monoamine oxidase, and dopac is further metabolized to homovanillic acid by COMT and monoamine oxidase. And it is also reuptake into astrocytes, which further metabolizes into homovanillic acid via COMT or MAO. Sir, I'll cover short pharmacology also. The levodopa and carbidopa. Levodopa is added to the CNS, which improves akinesia, rigidity, hypokinesia, and tremor in Parkinson disease. Carbidopa prevents the degradation of levodopa peripherally as well as centrally via inhibition of dopa decarboxylase. COMT is inhibited by in central system as well as peripheral system via entacapone and tolcapone, while monoamine oxidase is inhibited, especially monoamine oxidase type B. It is inhibited by selegiline and rasagiline. Amantadine reduces the reuptake of dopamine and increases the dopamine release into the synapse. And dopamine agonists act on the dopamine receptors, that is pramipexole, ropinirole, apomorphine, and rotigotine.
Okay, you can go ahead.
Yes, sir. Then moving on to dopaminergic pathways or circuits, 5 pathways are there: nigrostriatal pathway, mesolimbic pathway, mesocortical pathway, tubero-infundibular pathway, and the fifth pathway. So nigrostriatal pathway is the pathway starts from substantia nigra pars compacta, moves to the striatum. The role is for motor function and learning new skills. The motor symptoms of Parkinson disease are a result of dysfunction in nigrostriatal pathway, and the extrapyramidal adverse effects of antipsychotics are mediated by this pathway. The mesolimbic pathway starts from the ventral tegmentum, A10 area, moves forward to the limbic system, that is amygdala, piriform cortex, nucleus accumbens, and others. This is responsible for emotion, reward, reinforcement learning, and dopamine release during pleasurable activities. This pathway is implicated in drug abuse, gambling, and impulse control. Sir, antipsychotics block the mesolimbic dopamine receptors to decrease the positive symptoms of schizophrenia. The mesocortical pathway is responsible for cognition, working memory via DLPFC, and emotion and affect via ventromedial prefrontal cortex. The ventral tegmental area provides input to PFC and the septohippocampal regions. The antipsychotics, especially the older antipsychotics, may worsen negative symptoms of schizophrenia via this pathway. Fourth pathway, sir, that is the endocrine related pathway. The dopamine inhibits prolactin release via release from arcuate nucleus of hypothalamus and goes to the median eminence of pituitary. Dopamine blockade in this pathway by antipsychotics causes galactorrhea. And so the fifth pathway, that is the thalamic dopaminergic pathway. The dorsal posterior hypothalamus provides relay to the thalamus. This is responsible for sensory perception and autonomic function. The A11 area impairment is implicated in restless leg syndrome and may cause abnormal visceral or muscular sensations. D3 agonists are used for treatment of RLS. Should I move forward?
Yeah, you can move on.
Yes. So moving on to pathophysiology, the motor behavior is determined by balance between the direct and indirect striatal outputs. In hypokinetic disorders, there is insufficient direct pathway output and excess indirect pathway output. And hyperkinetic disorders have excess direct pathway output and insufficient indirect pathway output. In Parkinson disease, the degeneration of substantia nigra pars compacta neurons results in loss of dopaminergic stimulation. The direct pathway becomes less active and indirect pathway becomes more active, resulting in hypokinesia, rigidity, tremor, akinesia, and freezing symptoms.
Mainly, it is responsible for bradykinesia.
Yes, sir.
Okay.
Yes, sir. As we can see in the Parkinsonian state, the excitatory input to the cerebral cortex has been decreased and the inhibitory input has been increased. Moving on to hyperkinetic disorders. In ballism, there is sudden uncontrolled flinging movements of extremities. This occurs due to lesion of the subthalamic nucleus following a stroke, and the symptoms occur on the contralateral side. The subthalamic nucleus, the inhibitory input of the subthalamic nucleus is lost, resulting in excessive unwanted movements. In Huntington disease, there is loss of striatal inhibition to the globus pallidus externa and excess action. And there is excessive thalamic firing, and there is a decreased activity in the indirect pathway, resulting in unwanted motor movements, resulting in coriform movements. And further, when the disease progresses, there is a generalized atrophy of the striatum, resulting in hypokinesia or akinesia in later stages of disease. Moving on to blood supply. The major supplies via lenticulostriate branches of MCA. The recurrent artery of Hübner supplies the head of caudate and anterolentiform nucleus.
Can you discuss the other hyperkinetic disorder?
Yes, sir.
Pathophysiology. Other than Bellismus.
Sir, tremors, tics, and dystonia are other hyperkinetic disorders.
Yes, so
their mechanism and pathophysiology.
which lesion, where in the lesion in the basal ganglia will cause which hyperkinetic movement disorder?
Sir, pathology in the subthalamic, pathology in the subthalamic nucleus will mainly cause tremor, and
The subthalamic nucleus causes Ballismus.
yes, sir, Ballismus. Sir, striatal lesion will cause chorea. The subthalamic lesions will cause hemibalismus, and sir, the abnormalities in the loops between the basal ganglia and the thalamus and the cortex results in dystonia, and sir, tics result in the cortico-striatothalamocortical loop dysfunction. And sir, increased activity in the thalamocortical loops causes tremor. That is mainly, sir, lesion, sir, mainly in the ventro-intermediate nucleus of thalamus and subthalamic nucleus.
Yes, okay.
So lenticulostriate branches of the MCA provide blood supply. Recurrent artery of Hübner provides the blood supply to the basal ganglia via ACA. And mainly supplies the head of caudate and anterolentiform nucleus. And the anterocoroidal artery via ICA provides blood supply to posterior lentiform nucleus and the tail of the caudate.
So what is the lesion after anterior choroidal artery infarct?
Yes, sir.
Presentation of the patient.
Sir, I could not get you, sir.
What is the presentation of the patient after anterior choroidal artery infarct?
Patient will present to us with, sir, hemibalismus.
There is this triple H syndrome.
Sir, hemibalismus,
hemiparesis,
and hemisensoriness.
hemianopia.
Yes, sir.
Okay.
Sir, main blood supply of the head of caudate is by deep penetrating branches of ACA. The tail of the caudate is supplied by the MCA and PCA. Body of the caudate is supplied by anterior choroidal artery. Anterior putamen is supplied by ACA and MCA. Posterior is supplied by ICA and ACA, while anterior GP is supplied by AC, MCA, posterior GP is supplied by the IC and the MC. Substantia nigra has mainly PCA supply, and subthalamic nucleus also has a mainly PCA supply. Sir, take-home messages: three main basal ganglia pathways: direct pathway, indirect pathway, and hyperdirect pathway. So direct pathway selectively facilitates certain motor programs in the cerebral cortex, and indirect and hyperdirect pathway inhibit the execution of unwanted motor programs. ACH turns down motor activity and dopamine turns up motor activity. In hypokinetic disorders, there is insufficient direct pathway output and excessive indirect pathway output. And in hyperkinetic, there is excess direct pathway output and insufficient indirect pathway output. Thank you, sir.
Okay, one more. I wanted to ask, what is the other importance of basal ganglia? I mean, therapeutic implications of basal ganglia.
Sir, recently, neuromodulation and
Yes.
yes, sir.
So what is used in neuromodulation?
Sir, we can use deep brain stimulation. And
So which areas do we insert the deep brain stimulation, the stimulator?
yes, sir. For the tremor, mainly there is we can ablate the subthalamic nucleus or the ventro-intermediate nucleus of thalamus.
Okay.
Yes, sir. And
No,
sir,
it is not ablation. It is only stimulation by
yes,
stimulator.
yes, sir.
So what about Parkinson's disease?
Sir, in Parkinson disease, the GPI can be
Most
BBS
commonly
can be
used
done in the
is
GPI.
in subthalamic nucleus.
Yes, sir.
We can try in globus pallidus interna also, but preferred is subthalamic nucleus.
Yes, sir.
And what about dystonia?
Sir, GPI is a major target
In GPI.
in dystonia, sir.
Yes, and also in thalamus, but for thalamus mainly we use in tremors, which
Yes, sir.
are refracted to medical treatment. We can try.
Yes, sir.
And in GPI for chorea also sometimes we can use. We can do DBS for chorea in GPI.
Yes, sir.
So what are the functions of basal ganglia?
Sir, mainly to modulate and plan the programs of the cerebral cortex, that is the motor programs, the cognitive programs, and sir, emotional and the reward pathway.
Also voluntary motor control is important.
Yes, sir.
And motor learning. Along
Yes,
with
sir.
that, executive function,
Yes, sir. Executive.
behavior, emotion, and
Yes, sir.
stigma. Anyone wants to discuss anything or ask anything?
Hi, Dr. Ratnesh.
Yes.
Hi. So,
Yes, ma'am.
so what is physiological tremor?
Physiological tremor occurs in conditions of stress and excessive sympathetic overactivity. The physiological tremor has a rate of around 12 to 14 hertz and can be decreased via it is decreased after a stressful activity.
What is the pathway?
Ma'am, pathway, I don't know, ma'am. I'll have to read.
As you said, it is all because of the increased sympathetic release, adrenergic release.
Yes,
So, there is a tremor loop, and in the brain, it has like olivo, dendo, and rubro, thalamo, cortical pathways too. So, overactivity of these things will cause the physiological tremor.
okay.
And how is alcohol related to tremors? Like you see in certain patients, like essential and other things, alcohol, the consumption of alcohol will decrease.
Decrease.
Yeah.
Yes,
How is it?
ma'am. I'll have to read. I don't know.
Nothing. It's alcohol will increase GABAgenic neurotransmitters. So in all your loops, it's all GABAgenic mediated, right?
Yes.
All direct. And because of the overactivity of GABAgenic and these tremors and other things will set it up.
Yes.
Thank you.
Yeah, there are some questions in chat box. You can read once. Mm, Tick's pathway. Tick's pathway. Anybody want to answer? Dr. Noel, Dr. Ratnesh.
Yes, sir. Sir, mainly, sir, the in the sir, via the motor loop and the cognitive loop, there is overactivity in the motor loop and cognitive loop, which results in tic disorders.
Yeah, somebody has written overactivation of dopaminergic level in DLPCF. Anybody have any other questions? So, Dr. Noel is online. Let- Anybody have any other questions? Dystonia loop. What is Can you tell something regarding dystonia loop?
Yes, sir. So mainly, there is, sir, excessive. Just a minute. I'll have to go through the loop once, sir.
Yeah, you can go back to your slides.
Yes, sir. Sir, there is altered activity of the medium spiny neurons and the dysfunction of interneurons, which contributes to the involuntary movements in dystonia, sir.
Dystonia actually has a huge loop. It includes primary motor area, basal ganglia, thalamus, cerebellum, primary somatosensory area also. And
Yes, sir.
the exact pathway and mechanism is not known, but abnormal striatal thalamocortical pathway, then abnormal sensory motor pathway, sensory motor dysfunction, processing dysfunction, and even
Yes,
cerebellar outflow abnormalities. Everything can cause dystonia. So it's a huge pathway or a huge loop. The exact pathway is not known for dystonia.
yes, sir.
Okay, anybody want anybody need discussions? Any discussions? Why does breast tremor occurs in Parkinson disease? Mechanism of rest tremor in Parkinson.
So in Parkinson disease, dysfunction of the striato-pallidothalamo-cortical tracts, that is the mainly sir globus pallidus, and the cerebello-dentatothalamocortical circuits, the dysfunction occurs, which results in the rest tremor of Parkinsonism. Mainly, sir, globus pallidus internus and substantia nigra pars reticularis.
Yeah, anybody want any other questions? Then last question we will close the session. Dimmer switch model. Okay, so it was very nice, crisp presentation by Dr. Ratnesh, and he tried very in short time to explain us very detailed in anatomy and physiology and pathophysiology of various movement disorder. And I thank Dr. Noel and Dr. Nandini for moderating this session. And we'll post the PPT in group. And it was a very nice, short and sweet presentation for exam. So,
Yeah,
Dr.
sorry
Noel,
about connectivity.
if you
Yeah,
want,
Ratnesh
if you
presented
want, you
well.
can
Yeah, I think
closing
most of the
remarks.
points were covered. The important is direct, indirect, and hyperdirect pathway. It is important to know which is inhibitory, which is excitatory, how dopamine acts. Dopamine acts via D1 on direct and it is excitatory. It acts via D2 on indirect and it is inhibitory. And so decrease in direct and increase in indirect causes Parkinson's, that is hypokinetic, and reverse is in hyperkinetic. Anyways, good presentation.
Thank you, sir.
Okay, Dr. Ratnesh, if you want to ask any question or doubt, you can clarify from the moderator. Then we will close this session.
No, sir.
Yeah. So we'll close the session. Thank you everyone for attending this session. And from tomorrow, uh, we will have some more discussion on history and exam pattern in hypokinetic movement disorder. Thank you everyone. We will
Thank you,
close
sir.
this session.